Good morning, respected chairpersons, dear friends. I'll be talking about Smile Xtra, when and where. Let's see where we can use this procedure and what are its indications. So Xtra procedures are basically a special class of refractive surgeries wherein accelerated cross-linking can be combined with various corneal refractive procedures such as PRK, LASIK, as well as SMILE. And these cases are generally reserved for those patients where the topographic indices or clinical history suggestive of corneas at risk for ectasia. But these procedures are not very popular amongst refractive surgeons. Why? Firstly, the eligibility criteria are not very well defined. The cross-linking protocols are also not very clearly defined. There could be potential side effects of haze and hyperopic shift over long term. And there is an additional cost which is involved, and also there is a lack of long-term data. So in 2015, we published this paper on the clinical outcomes of Smile Xtra in patients with thin corneas and borderline topography. And after our publication, actually, there have been many more publications on different types of extra procedures, PRK Extra, LASIK Extra, and Smile Extra as well. So based on our experience of over 1,000 eyes, we actually have published this eligibility criteria for Smile Extra. So if any of these are the risk factors basically. If 3 or more risk factors are present in a patient, then the patient should be counseled for Smile Extra. So age less than 30 years, suspicious topography. When I say suspicious topography, that does not mean keratoconus. It could be isolated inferior-superior asymmetry, anterior or posterior elevation, thin pachymetry, RST between 250 to 280 microns, refractive error more than 6 diopters of SE. We have also added some pentacam criteria, which is final bad D value of more than 1.65, CBI of more than 0.5, and TBI of more than 0.29, and also presence of additional risk factors such as family history of keratoconus or history of eye rubbing. So if 3 or more of any of these risk factors are present, then instead of SMILE, you should advise Smile Extra. So surgical technique is just do a routine SMILE first, and followed by this, you can inject 0.1 ml of Vibex extra riboflavin and apply it to the interface for 60 seconds. Wash it and then expose the eye to ultraviolet A radiation at 45 milliwatt per centimeter square for 75 seconds through the cap, and this delivers a total energy of 3.4 joules per centimeter square. So generally there are no intra or postoperative complications. The only thing that you can observe in the post-op period is sometimes a very mild transient interface haze, which fortunately is not visually significant. Most patients will see 6/5 even through this very slight haze, and it also clears over time. ASOCT shows the depth of stromal demarcation line at around 220 microns at 1 month, and this clears over time. So just showing few case scenarios where Smile Extra was done. So this is a low myope patient, 21-year-old female. Pachymetry is less than 480 microns, and the RST was also, I think we've not mentioned here. The bad value you can see is 2. So she had 3 risk factors due to which the Smile Extra was performed. This is case scenario second, where there is a high myopia. Both eyes spherical equivalent is more than 6. Age was 30, which was again young age, and RST was 270, TBI was 0.89. So again, this classifies to go for a Smile Extra procedure. And this is case 3, where the spherical equivalent is 6. Age is fine, 38-year individual. Corneal thickness is good. RST is also good. But again, bad D final value is 2.56, and TBA is also on the higher side. So this, in spite, and if you look at the bad display, it looks like a picture of form first keratoconus. However, since the patient is an older patient, we have still advised the patient Smile Extra, and patient did very well. So we published a paper on incidence of ectasia after SMILE from our center very recently in JRS, and we found that the incidence was 0.15%, and this was more in the borderline eyes for which SMILE was done, and the other set of around 500 eyes where Smile Extra was done did not develop ectasia in any of the eyes. So this is another paper showing the comparison of early outcomes between SMILE and Smile Extra, and they found that the efficacy of Smile Extra was slightly lower, but safety index was similar, and corneal biomechanics showed that the post-op corneal resistance factor was significantly higher in extra group versus the SMILE group, and some people have also done it in FFKC cases, and they have also followed up for 24 months and did not see any progression of ectasia in these borderline cases. So to conclude, simultaneously done cross-linking with SMILE could be a safe and effective procedure for prophylaxis of corneal ectasia in borderline eyes. The decision to perform Xtra is a case-to-case basis, and anecdotal evidence shows that biomechanics with SMILE Xtra may be better compared to while doing SMILE alone, and it still needs to be confirmed with further studies. So we still need to see long-term results of Xtra procedures. So this was my take on SMILE Xtra. Thank you so much.